Sir, we are on live now.
Yes, yes. Good evening, everyone, and thank you very much for Indian Arthroscopy Society to continue this webinar. So, in this month's webinar, we have two moderators, Dr. Ranjit Panigrahi, Senior Arthroscopy Surgeon from Bhubaneswar, and also he was a past TC member of Indian Arthroscopy Society, and Dr. Soumyadeep Datta from Kolkata. Over to you, Dr. Soumyadeep and Dr. Ranjit.
Yeah, thanks, Dr. Sandeep, for giving me the opportunity, and thanks, IAS, for giving me the opportunity to moderate this session. Now we have the first talk is by Dr. Deepak Chaudhary from New Delhi, and the two good case presentation, one by Dr. Ankit Marfatia, and the second one by Dr. Vinay Kumaraswamy. So to start with, we have the talk with Dr. Deepak Chaudhary, who is the so to say pioneer of double bundle reconstruction in India, and very few nowadays are doing double bundle reconstruction, and so to say he is the only one who is doing double bundle reconstruction, and he is now working as principal director at Arthroscopy and Sports Injury Center, BL Kapoor Max Super Speciality Hospital, New Delhi, and he was instrumental in creating the Delhi Sports Injury Center, and he was the director of the Delhi Sports Injury Center. Over to Sir, Dr. Deepak Chaudhary, sir. You can please start your talk.
Yeah, thank you, Ranjit, for your very kind words. And thank you, Sandeep and IAS, for giving me this opportunity. Is my screen visible?
Yes, sir.
And am I audible?
Yes, sir.
Okay. So my topic would be double bundle ACL reconstruction. Is it still relevant? So my journey with double bundle ACL started in the year 2006 when I met this great man, Dr. Freddy Fu. Actually, I visited him in 1999 also. And then thereafter, I started doing my ACLs. And obviously, initially, they were single bundle ACLs. And in 2006, I visited him. And thereafter, I started double bundles. And there has been no going back or looking back after that. So, we must understand the rationale of double bundle ACL, and the rationale is anatomy. Orthopedic surgery is all about restoration of anatomy, and certainly ACL reconstruction is no exception to this rule. We all know that ACL is made up of two bundles, the AM bundle and the posterolateral bundles. So these two bundles are not only anatomically different, but these two, they also perform different function. And the AM bundle, it is the primary restraint in flexion, and the PL bundle is the primary restraint in extension. And this figure shows you the anatomy on the femoral side, that there is an intercondylar ridge or the residence ridge, and the ACL has to be below that. And the AM lies posteriorly and the PL lies anteriorly. In between, there is a bifurcate ridge. So the anatomy has been very well studied, and as is the trend in recent years to reconstruct anatomically. And so for that reason, the ACL double bundle still carries its relevance. So as I said, the two bundles have got different function, and by just restoring one bundle, you cannot restore the normal kinematics and the biomechanics of the knee joint. And moreover, the footprint of the ACL on the tibial side, as well as on the femoral side, it is close to about 16 to 18 millimeters. And single bundle ACL reconstructions, the normal diameter is about 8 or 9, and which effectively restores only about 40 to 50% of the footprint. By reconstructing by way of double bundle, we usually get a diameter of AM about 8 and the PL about 6. So which makes about 14 and sometimes even 15. So which covers close to about 80 to 90% of the footprint. So the footprint coverage is very important. The more the volume, the more the collagen, the better is the strength of the ligament. So that is the rationale behind reconstruction of any ligament, and also the double ACL also, since it has two different bundles and which perform different functions. So anatomical ACL reconstruction, the advantages are that it replicates the normal anatomy, And as a result, it restores the kinematics and the biomechanics of the knee joint, resulting in long-term knee health. So what are the principles of ACL reconstruction for a double bundle? They remain as for any other ACL. One must appreciate the native anatomy of the ACL, judge it, what is the diameter, and the surgery has to be individualized according to the specific needs of the patient, the anatomy specific of the patients. The graft should be placed without impingement either of the roof or the PCL. So you have a very limited space where you have to make the two tunnels, and as such the margin of error is very small. And again, we have to use a high strength, low morbidity graft and rehabilitate the knee aggressively if you have done a good fixation. So why double bundle? The logic behind making the shift from single to double was that single bundle ACL reconstruction does not adequately restore knee stability in all cases, particularly the tibial rotation, because we are not reconstructing the PL bundle. And it was found that traditional ACL reconstruction techniques using single bundle have resulted in normal IKDC scores in only 61 to 67% of the patients. And about 10 to 30% of patients with single bundle, they complained of pain and some amount of instability. And even arthritis was observed in large percentage of patients with single bundle. So these were all the drawbacks of the single bundle, which led to the evolution of the double bundle in late 1990s and early 2000. There are, of course, not every patient is a suitable candidate for double bundle, and there are certain contraindications, especially if the footprint is less than 14 millimeter. In a multi-ligament injury, you don't want to make that many tunnels and weaken the bone. And advanced osteoarthritis, when intercondylar notch is less than 12 millimeters, and open physis is also not a good indication. So there have been concerns with double bundle because of which it fell into disrepute. And the concerns are, is this procedure going to be better than a single bundle? The literature is divided, and the long-term clinical outcomes, they show that they are similar. Then another concern is, does every patient require ACL double bundle? As I said, not every patient is not a candidate, and everything depends on the specific demands of the patient and the specific anatomy. Another concern is, by increasing the number of tunnels, are we creating problems for revision surgeries down the line? Our own experience of about close to 3,000 procedures reveal that this concern is just there as a myth rather than a reality. And we have been able to, perform revision ACL double bundle even in our own cases of failed double bundle in certain cases. Then, do the theoretical benefits of double bundle outweigh the risk of, by increasing the number of tunnels, are we increasing the risk of graft impingement? So these are all concerns, but once you have mastered the techniques, these concerns really don't come into much into reality. So we have an experience starting from 2006 until 2022. Now close to about 2000. Now this figure is more than 2000 double bundle ACLs. So this is a surgical video. This was a torn. This was a revision surgery. So this initial ACL graft is being removed to make way for the two bundles. We make two tunnels on the tibial side. Again, this area, as I said, is very restricted, and one has to. There is margin of error is very less, and we make the PL tunnel, and then as you can see that these two cover the footprint of the ACL very well on the tibial side. So once we have done with the tibial tunnels, then on the femoral side, we use eyeballing. I use eyeballing for the AM bundle, and then drill it to the desired length. And depending on the diameter of the graft harvested, the appropriate reamer is used, and the appropriate depth is selected. And you can appreciate that AM bundle. Now, at this point of time, we use a offset, the 5 mm offset, and for making the drilling the PL bundle. So the logic of 5 mm offset is that usually the PL is about 6, and that makes a bony wall of close to 2 millimeter in between the two bundles. Then further, the rest of the procedure is just pulling up the graft first of the PL side, and the similar process is repeated for the AM bundle. So this is the AM bundle being pulled up. We reinforce the AM bundle by a brace in almost all our cases. And as you can see in full extension, there is no impingement and the graft are in perfect position. This patient also had a bucket handle tear, and which was also tackled in the same sitting. It was reduced in its position. And check the reducibility. Some of these tears, especially if they are long standing, it becomes difficult to reduce. So we have to sometimes open the joint by pie crusting. Pie crusting should always be done, especially on the medial side in a tight compartment. And so this was a bucket handle tear. The usual principles of meniscal repair are followed, of preparing the good meniscal bed so that there is in growth of blood vessels and growth factors. And once you have used a combination of shaver and rasp to freshen the edges of the meniscus, remove any fibrous tissue. And we also do this bit of needling to increase microvasculature. And this all inside devices, they work very well in our hand. And in all our cases, in most of the cases, we are able to, complete the meniscal repair using all inside devices, except for perhaps the most anterior part where we use the outside in technique. So in usually such cases, close to about sometimes 8 to 10 these implants are used, because we want to make a robust construct. And the usual principle is to add these all inside anchors at a distance of about 4 to 5 millimeters. So as you can see at the end of it, there's a very robust type of construct, meniscal repair. So we sometimes do this CT scan post-operatively to validate our tunnels. This is not done routinely, just to validate for academic purposes, where patient also agrees. And you can see that the tunnels are quite anatomical. Then post-op MRI confirms that there is a good ACL, and the graft has also medial meniscus repair. Early post-operative changes are there. And in 18 months, you can appreciate both the bundles of the ACL, the AM as well as the PL on the MRI, and the meniscus also shows good healing response. So this is another 10-year follow-up of one of our double bundles, and you can appreciate very good vascularization. That is the AM bundle, and the PL bundle can also be seen. There is no impingement. So this arthroscopy was done for a different purpose. And as you can see, the double bundle is working very well in this patient. This is a 15 months follow-up of the patient doing high-level activities. So usually our patients of double bundle, they return back to their active sports anywhere between 6 to 9 months, depending on their level of rehabilitation. We put them through we have a very high-end isokinetic system and zero gravity treadmill and other equipments which enable early return to recovery of the injured athlete. What does the literature say? Literature is always divided, and there are both reports in favor and against the double bundles, but wisdom always lies at a point equidistant between two vices. So every case is not suitable for double bundle, as I already said, but our own experience shows that double bundle has got good stability. The chances of re-tear are less, and it provides more rotational stability. So recommendations for double bundles are not indicated for every ACL tear, indicated in young athletic populations engaged in competitive sports. It enhances the rotational stability. There are better subjective outcomes at midterm follow-up, as our own studies show, fewer graft failures, and important to understand that double bundle reconstruction is a concept and not a technique. How to improve outcomes in ACL reconstruction? Correct patient selection is again very important for double bundle. It has to be anatomical, whether you are doing a single bundle or a double bundle. The rehabilitation has to be individualized according to the needs of the patient. And again, treatment of associated injuries like meniscal, cartilage restoration, concomitant injuries. They must be, you must make all attempts if you have a good experienced team to fix all the ligaments in one go, and alignment correction wherever required in selected cases. So the take-home message, especially in elite players, is that results of double bundle are overall very good. Revision rates are low. Surgical technique is again very important because the margin of error is less since you have to make 2 tunnels. It is better to operate better than not to operate, especially in a young athletic population. Again, timing is important. You must operate early wherever required to prevent the cartilage and meniscal damage. And females and smokers, they do not have that good results. And cartilage and meniscus are again important to repair in the same sitting. So the take-home message is double bundle ACL reconstruction is relevant as long as ACL anatomy is relevant. And I strongly feel that since it is based on anatomical principles, it will wage a comeback. There has been a recent lack of popularity, but I am sure that something which is based on anatomy cannot go wrong. And thank you very much for your kind attention, please.
Thank you, sir, for an excellent presentation on the double bundle ACL reconstruction. It's an eye-opener for all of us and for the juniors also. Sir, I have a question. When these both the 2 femoral tunnels, if they coalesce, there is a blowout of this bony bridge, what is your bailout technique in this scenario?
Actually, Ranjit, we have in our early cases, and even somehow, somewhere, even now also, this sometimes happens that instead of that 2 mm bridge, which normally happens, there is coalescence, but ultimately it doesn't make any difference because the 2 tunnels are already there, that there is an exit point. And so we are able to, place the PL tunnel in the PL part and the AM tunnel in the AM part. So even in many cases, even our tunnels coalesce, that doesn't really affect the result. Sometimes the posterior blowout occurs, and in that case, sometimes we have to change the direction of the AM bundle, and but more or less these mistakes do occur in your learning curve. But now more or less the results are quite predictable and reproducible.
Sir, you have already told during the revision situation, if you have done a double bundle ACL reconstruction.
Yeah, in many of our cases, we have patient wanted double bundle, so we harvested from the opposite side, and there was not much problem, and we could do it in a single stage only.
In the revision also.
Even in revision. About few years back, we did a live surgery also on the such case, a revision in Gangaram Hospital, and that was a revision case of double bundle somewhere done outside, which we revised again by a double bundle technique.
Okay, every time you are again doing the double bundle, or you are creating a single tunnel also? If you are creating a single tunnel, how you manage your tunnel and where you put your tunnel?
In revision situation. In revision situation, most of the time the tunnels are both our tunnels are anatomical. There is no chance for them being non-anatomical because the tunnels have been made in a restricted space. So we utilize the same tunnels to use, and sometimes what we add is if their tunnels are a bit widened, we do add a biocomposite screw just to fill up that tunnel. But in none of our cases we have to use any bone graft or do a 2-stage revision. We have been lucky that way that we have done in a single stage.
Sir, another thing in athletic population also in Asian countries, they have smaller knees as compared to Western people.
Yeah, I agree. But most of the Ranjit, I agree. But most of the players that we get they are wrestlers or even footballers, and then we make a on the table decision. If we find that the footprint is small, we change our decision to make we don't make it an ego issue that we have to do a double bundle. Yes, in some children, the younger population, they do not have that big a footprint. And in that case, we explain to the patient that we are doing a single bundle. And so broadly speaking, it is the ratio is 60/40. 60% of our cases are double bundle and 40% are single bundle.
And do you agree, sir, that double bundle reconstruction, double implant, double cost, and double trouble?
So actually, most of the patients that they are beneficiaries who get their reimbursement from their agencies, or they are covered by TPA, and this is not much an issue. When we explain to them, we give them the option, and most of them, in our cases, they opt for a double bundle, and we are happy to do that.
And do you believe, sir, these double bundles, they become single bundle over a period of time?
No, that is so. As I told you, there are a lot of patients in which we had to do a re-arthroscopy for some other reasons. They had a meniscal tear or something, and as you could see in one of our cases, the double bundle was exactly there. It was very well vascularized, and the double bundle remains as it is. Both the bundles.
Thank you, sir. Any other questions?
Modi sir, very nice presentation. Sir, what is you have said that you take the 14 millimeter footprint of ACL as a cutoff for double bundle and tunnel notch of 12 millimeter. Do you measure it pre-operatively, or do you measure?
No, it is just it is more of a decision taking during surgery. If we feel, and then at that with a calibrated probe we measure, and sometimes when we feel that there's not enough space for double bundle, and making double bundle would cause more problems rather than, then we reverse the decision usually on the table. It's not a pre-operative.
Okay, thank you.
Actually, I showed last year I was in Chicago to attend a advanced knee course under Dr. Rob Laprade. And my question to him was that you are so much pioneer of ligaments, and everywhere you are advocating restoration of anatomy, whether it is the PCL, whether it is the MCL, you want both the POL as well as the tibial. Why this stepmotherly treatment towards the ACL where you are not advocating double bundle? Then I showed him on the cadaver my technique, and he was, quite satisfied. And he said that if you are doing it that way, and if your ligaments are successful, you keep carrying on. The problem is that most of these, many of these surgeons, they encountered this lot of technical difficulties while making single bundle. But when I showed him my technique with freehand, he said, you just carry on. So that further enthused me to carry on with these double bundles.
Okay, any other questions from the panelist and Naresh? Okay. So we'll move forward. Thank you, sir. Thanks for an excellent presentation. And Somyadip, can you take over from here on?
Sure. Thank you. I think now we go to the case presentation. I think first case is from Dr. Binay Kumarswamy. He's a very young, dynamic arthroscopy surgeon from Bangalore. So Dr. Binay, please share your presentation. Over to you, Dr. Binay.
Thank you. Good evening. I'm Dr. Vinay from Bangalore. Big thank you to IAS for giving us young surgeons the opportunity to present our work. And thank you for continuing this online, educational initiative that started during COVID, and it is continuing still. Thank you very much for that. I'd like to share my screen now.
Yeah, done.
Yeah. So I'll be presenting 3 cases of mine where I've had to do a revision. They're not necessarily my cases. One of them is my case. 2 of them are cases done by others that I had to revise. And I learned a lot from these cases. Such are these cases. Sorry. First case is a 50-year-old female. She had a knee arthroscopy done 3 years back for a medial meniscus tear. partial medial meniscectomy was done. But unfortunately, even after the surgery, her symptoms persisted, and she continued to have the same pain that she had before the surgery. And she visited multiple surgeons. She had multiple consultations, but she could not find any relief. She had severe pain, and there was difficulty in walking and carrying out her day-to-day activities. When we examined her, she had severe tenderness on the lateral aspect of the knee. The alignment of the knee was normal. The blood workup for inflammation and infective etiology were all completely normal. This was her X-ray when she presented to us. Quite innocuous. There is a slight reduction in medial joint space on the X-ray. But when we got the alignment X-rays done, the alignment X-rays were normal. She had normal alignment. So we further proceeded and advised her to get another MRI done. So on the MRI, she had got a medial meniscus surgery done. So the medial meniscus was still showing grade 2 signals on the MRI. There was a little bit of blunting because of the previous surgery. But what was also interesting to note was there was a hyperintense lesion on the posterolateral aspect of the knee that was very prominent, and that was consistent with the location of pain that she was pointing it out. So now looking back at the same X-ray that I had presented earlier, this lesion is quite obvious on the posterolateral aspect of the knee. There is a calcified lesion on the posterolateral aspect of the knee, and her pain was also typically in the posterolateral aspect of the knee, where we could not touch that part at all, and she used to wince with pain. And this was the MRI picture there. There was a central nidus kind of lesion with surrounding edema. So finally, we decided that we'll have a relook. The working diagnosis we had was either a calcific vascular lesion. We had our vascular surgeon also along with us washed up in case this, because we are going to operate near the popliteal artery. If there is a vascular lesion, we had to have a vascular surgeon along. It could be an infection is something we thought, and it could be a lateral meniscus pathology because the pain was all localized to the lateral side. We put the patient in a floppy lateral position, did a diagnostic arthroscopy first, and found out that the intraarticular structures were all normal. There was no cartilage damage, there was no meniscal pathology, there was no ligament pathology. We checked on the C-arm to confirm whether we can see the calcified mass in the C-arm, and luckily we could pick that up on the C-arm. And this was the approach finally we took. This was a posterolateral approach where we dissected the common peroneal nerve and tagged it. And the approach was posterior to the long head, to the biceps femoris tendon. The white structure we can see is the biceps femoris tendon, and we went between the biceps femoris tendon and the lateral head of gastrocnemius. And luckily, with finger dissection, we could get out a 3 centimeter or 4 centimeter by 3 centimeter hard calcified mass. It was very loosely attached. It was not strongly attached to any other structure. We sent it for biopsy, and the biopsy came back as a spindle cell tumor. A spindle cell tumor has been described around the knee, and the arrow mark on your right is the myxoid degeneration that is seen with spindle cell tumor, and these are the spindle cells. There were not many mitotic figures. There was not much of necrosis, so this was not a malignant lesion. So the final diagnosis was a spindle cell tumor, which she had from the beginning, because the MRI showed a meniscal tear. Probably someone reported on a meniscal tear. She was operated and a meniscus surgery was done, and her symptoms didn't come down at all. So she presented after 3 years, continued to suffer for 3 years. And finally, we could help her out, and her symptoms came down drastically. By the time of stitch removal, she was much better. So spindle cell tumor around the knee is a rare case. There are very few cases that have been reported in the literature. it can cause a diagnostic dilemma and can be confused with many other knee conditions. There are many reported spindle cell sarcomas of the popliteal fossa. So we have to be we have to be careful when we are treating these conditions. We have to get a histopathological examination for every case to rule out any sarcomatous condition. And what I learned from this is clinical examination and reading your own MRI and correlating them with the clinical findings are of paramount importance. If we don't do that, someday or the other, we are bound to err. High index of suspicion for such cases is important. This is one case. Shall I go ahead with my second case?
Yes, please go ahead.
Okay. So the second case is another 24-year-old male. He had a ACL reconstruction done by some other surgeon 2 years back. He is a military attaché. That means he's not actual military person, but he stays with the military, provides intelligence and interacts with he acts as a liaison between the military and the local population. He has to go to a lot of hilly areas. Sometimes when attacked, he has to run also. So his main complaint after the ligament surgery was that he could not run. He was stable, the instability had disappeared. But the moment he used to start running, he could not run. Once his camp was attacked by terrorists and he tried to run, he couldn't run at all. First step, he had severe pain and he somehow struggled out of that place. And walking more than 500 meters was painful. When we examined him, his alignment was normal. When we examined him, there was no joint line tenderness. The range of motion was only 5 degrees to 130 degrees. So there was 5-degree extension lag, and there was another 10 degrees flexion lag. So there was 15-degree reduction in the range of motion. X-ray and the implants were normal. So we went ahead and got an MRI done for him. And the MRI showed a cyclops lesion anterior to the graft. So this is the graft, if you can see my pointer. And anterior to that is extensive cyclops lesion. And that was preventing him from running and walking too much. So conservative treatment had failed. He took extensive physiotherapy with no improvement. And we decided to go ahead and have a relook with him. So when we went in, this was his picture. The entire notch was filled up with hypertrophic cyclops or hypertrophic fibrous tissue. We palpated that, we confirmed that. Then we went ahead and started shaving it. And finally, when we removed the entire cyclops lesion, we could see the graft behind the ligament, behind the cyclops lesion. So this was the graft. And now there was a diagnostic dilemma for us what to do next. Now we have removed the cyclops. The graft was looking a little lax, and the anti-Lachman, the anti-Troyers, when we did intraoperatively, was also loose. So we had two options at this stage: either leave the patient here and hope that his symptoms recover, or do a revision ACL reconstruction. This was already his second surgery. The graft was looking a little lax. So it is a question of what the surgeon feels. That time we felt that it's better to give him a stronger graft. So we went ahead and we revised his ACL also. We took a bone patella tendon bone graft, and we took down his ACL graft also. And after that, we fixed it with metal screws. And this was the final picture of the bone patella tendon bone graft. So post range of motion, his range of motion also had not returned until we revised his graft. So finally, we got good range of motion. The terminal extension lag came back and it became normal. He has good stability post-op. Now it's only 3 months since the surgery. We don't know whether he'll be able to run or not. So cyclops lesion, even in this era of aggressive rehabilitations do happen. We have to look out for them, and it can lead to suboptimal results if it's not treated appropriately. The last case I'd like to present is a 24-year-old pilot. This was my case. I had done ACL reconstruction for him. He had come to me with a chronic ACL. He had an ACL tear 5 years back, and he did not get operated for it. He came with a bucket handle medial meniscus. He had lateral meniscus posterior horn repair also done. So we did a ACL reconstruction, medial meniscus repair, lateral meniscus repair. For pilots to get back to their duty, they have to do a duck walk. They have to get into a squat position and walk for 20 meters to rejoin duty. This is something which is mandatory. His complaint was that he could not do the squat walk. So terminal 10 degrees of flexion was limited when we examined him, and there was a 5-degree extension limitation. There was tenderness in the retropatellar area. His alignment was normal. We tried to do physiotherapy extensively, it didn't improve. And finally, we had to get a repeat MRI done to find out what is happening. What we found was in the retropatellar area, there was a hyperintense signal, which was sitting right behind the patellar tendon, and that is where he was complaining of pain. It was correlating with the T2 image also. So since conservative had failed, we decided to go in and see what is the issue. We spoke to the radiologist when we did this MRI. He told that it could be a metal artifact. Unfortunately, we went in and we did a diagnostic on him. The menisci had healed well in 4 months. Middle meniscus, we had put some 9 sutures there, inside out, all inside and outside ins. So the meniscus had healed. We could not find any metal implant, but we could find that the fat pad was hypertrophied, and fat pad was impinging against the ACL graft. It was not a cyclops, it was a fat pad hypertrophy. So we cleared his fat pad. This was the meniscus repair that we had done that had healed well. And finally, we cleared all the fat pad. The ACL graft was also intact, it was not lax. And after this, his symptoms went back, his symptoms came down, and he could, after 2 months of rehabilitation, he could do a squat, he could do a jump, and he joined back service. So the diagnosis in this case was a hypertrophic fat pad with anterior scarring post-knee arthroscopy. There are very few case reports of this. It's a little known entity. There was one case study where 25 patients with anterior knee scarring were released by arthroscopic fat pad release. Out of that, 11 were post-ACL patients. 21 of those 25 patients did well after arthroscopic anterior interval release. 4 patients supposedly did not do well. So take-home message from me is very important in all cases, and especially in revision cases, as we saw in our first case. Because the patient was not examined properly, the spindle cell tumor was missed and a meniscectomy was done. Cyclops does happen even in this era of aggressive rehabilitation. Anterior scarring post-knee arthroscopy can result in suboptimal results, and it is a defined entity. Thank you.
Thank you. Thank you, Dr. Binay, for nice presentation. So, any question?
Yeah, Dr. Binay, in your first case, all the 3 are very interesting cases. In your first case, you told after making it slopey lateral position, we did the scopy. So how you did the scopy in slopey lateral position?
Yeah. So we almost knew that the knee arthroscopy was not the main way that we were to solve her problem. So assistant was keeping the hip internally rotated and we did a quick diagnostic round here. Since the patient was in floppy lateral, we went ahead and did the. So the primary aim was we wanted to go from the back and operate. Had we kept her supine and then done the arthroscopy, then we had to redrape her and reposition her and then again start the surgery. So we kept her in floppy lateral position. One assistant was keeping the knee externally rotated, and we could go ahead and do the scopy. It was a quick scopy and we couldn't find anything, and we continued with the open procedure.
Because it is very difficult to do a scopy in floppy lateral position, and those scopy marks are not visible also in your video. So that's why I asked.
The portals are on the other side.
Okay. And in your second case, it is because of the debridement of your cyclops. Some of the ACL fiber got torn, and you felt the laxity of this graft, or as such the graft was loose and lax. That's why you revised the case.
We all know that after a while, hamstring graft tends to become a little lax. So it might be the normal laxity also that creeps into a hamstring graft. But that problem I had was if I do the cyclops removal and then he continues to be symptomatic, partial graft rupture is the reason. If it was the reason for his pain, then again I'll have to cut a sorry figure that he continues to have symptoms even after the second surgery. So I wanted to exercise all the options and give him the best chance of recovery. And in private practice, I can't tell him that I'll do this, and there is a big chance that you may not improve after this surgery also. So I didn't want to take the chance. I know that there are a lot of people who would have just cleared the cyclops and left it, and he might have improved also because of that. This is some decision that I took during the surgery. I felt this was the right option to do. I gave him a stronger graft, more stronger than a hamstring graft. So I took down the graft and did a bone patella tendon bone.
Okay. To be on a safer side, you did the surgery. Very good. Excellent presentation, all the three cases. Then we can move forward for the second case. Dr. Soumyadev?
Yes, now the next I will go to the President Dr. Ankit Marfatia. He's from Mumbai. Dr. Ankit, can you please go through your presentation?
Hi. So after this amazing, interesting cases that we just saw, coming back to something that is little of debate, uh, there is a lot of things that I learned with this case and the next few cases that I did after this. How to navigate ACL with a medial meniscus root tear in a varus knee. I'm Ankit Mafitya, assistant professor from Mumbai. Thank you, IAS, for giving me this opportunity of talking. So let's go to the case. It's a 53-year-old male. He had a fall from stairs. He had a twisting injury of the left knee. He's a hypertensive.
One second, Dr. Ankit, can you make it?
Am I audible?
Yeah, you are audible. Your
Please.
screen is not in the slideshow mode.
Is this
Slideshow, can you make it a slideshow? Make it, yeah.
Is that fine, sir?
No.
No? Okay, one minute.
Dr. Ankit, please close the presentation, go to the presentation modes.
I'll
Then
change it. Yeah. Sorry for this. I'm so sorry for this delay. Yeah.
No, it's not happening.
Hmm.
I think if it's not happening, shall we continue like this only?
Yes,
We
yes.
can
Is that
yeah,
fine?
see.
Continue like this,
Yeah.
we are able to see.
Okay. Thank you. Thank you so much. So it's a 53-year-old. Just 1 minute. Let me just try one more time. Uh,
Yes.
Yes, it's okay.
yeah.
Yeah.
Okay.
Yes,
Yeah.
perfect.
So it's a 53-year-old male. We had a history of fall from a stairs, had a twisting injury of his left knee. He's a hypertensive. His anterior draw was grade 2 positive. Lachman was grade 2 positive. Posteromedial joint pain, McMurray was negative. He had swelling initially and he was conserved. He was offered surgery somewhere else, but he waited it out. And 2 months later, he presented to me with these X-rays. He had also got an MRI done, and the MRI showed a complete tear of the ACL with partial buckling of the PCL. The MRI was done immediately after the injury. He also had a medial meniscus root tear, which is seen by the ghost sign. In his axial and coronal cuts also, the medial meniscus root tear was noted. I got his standing scanograms done, and he did have a varus in this tibia with 79 degrees was his MPTA. His JCLA was also 3.8, but that I assumed was because of his root injury and his 2 months delay from surgery. So now my diagnostic dilemma was what to do. Only do a diagnostic arthroscopy, ACL reconstruction, ACL with root repair, ACL with HTO, ACL with root repair with HTO, medial open HTO only, and stage the procedure, lateral closed wedge HTO, but I did not find the slope to be of too much hindrance. So I reviewed the literature. So all the literature stated that doing a open wedge high tibia osteotomy with an ACL reconstruction does have good results in active symptomatic ACL deficient medial OA patients with varus malalignment. Uh, Correcting the deformity in the knee in multiplanes with high tibial osteotomy results in increased stability and less stress and strain on the reconstructed ACL. Simultaneous HTO with ACL will lead to a better satisfactory functional outcome to the patient. Then my next research was, does a root repair also help in such patients? So there was one paper that I found by Dr. Bancha, which stated that doing a medial meniscus root repair along with an HTO will help in improving the patient's outcome as well as preventing progressive osteoarthritis in the medial side of the knee. So what I planned, my approach would be a medial side hamstring graft, harvest the hamstring graft, distal release of the MCL, because I wouldn't want to do any more pie crusting as I'm already removing the medial side of the hamstring. I would be doing a diagnostic arthroscopy, going in preparing the ACL femoral tunnel, medial meniscus root repair with a suture anchor because I wouldn't want to have too many tunnels in my tibia. Then preparing my ACL tibial tunnel and then going ahead with the HTO using a plate while protecting the hinge as well as the ACL tunnel. On the right is the left meniscus root, which was it was torn and was I did a partial meniscectomy, white zone. Medial meniscus did show some size of fibrous you've seen in the red, uh, and that was something that was a flimsy issue only. So then I went ahead and prepared my femoral tunnel using the standard uh, anteromedial portal, and then I went ahead with the medial meniscus root repair. Again, looking at the root, I used the jig placed as a footprint hole, and I passed my chia wire initially, and then after passing the chia wire, I passed in my my suture anchor, my all suture anchor, yes. So there was a slight translation of the tunnel anteriorly, slightly, that's what I felt. However, it was because of the MCL that this had happened, that the tibia was seeming to be that it was slightly anterior. Well, I went ahead and sutured my medial meniscus root. One of the sutures were not very strong, whereas the second one, which is the white one, was pretty strong, and it was holding my root back in its place. I went ahead with my tibial tunnel preparation, and then I moved ahead to my high tibial osteotomy. The first picture is where my osteotomy site would be. The second wire is my hinge protection wire. Usually people put the wires from the femoral end and protect the hinge. I put it from the tibia and take it out from the femur. I went ahead with the standard osteotomy as I calculated with my pre-op planning. I did a cautery cord test and saw that my axis has been realigned. And while putting in the screws for the HTO, I used a chondrocyte harvest device. You can use a dilator or a reamer to protect the anterior, protect the tibial tunnel, the ACL tibial tunnel. I made sure that my anterior most screw was going posteriorly. There are devices available in the market which help in preventing this step of surgery. However, because of affordability, this was the plate that I had used. And now you can see my hinge wire is looking as if it's come from the femur onto the tibia. So that is how I put it. I pass it through my tibia, going up to the femur, and then pull it out from the femur while protecting the hinge while doing my final fixation. This was my ACL reconstruction that was done after passing my, and this was the post-op X-rays of the patient. In the post-op X-ray, the ACL screw, I could have used one size smaller screw. Looking at it, it may be in the joint. However, there was no impingement intraoperatively. I kept the patient nil weight bearing for 4 weeks, closed chain exercises. Knee range of motion was limited to 90 degrees flexion in the first month, then toe touch weight bearing, progressing to full weight bearing as tolerated after 2 months. So the take-home message is ACL with a medial meniscus root repair with a high tibial osteotomy is a technically demanding procedure. However, using an all suture anchor for the root repair will decrease the load on the medial compartment and aid in the functional return. And also it will prevent the tunnel coalition that we are worried about, as well as even the osteotomy site may cut out the wires that you transtip suture. Any questions?
Thank you, Dr. Ankit, for very nice presentation. So, any questions?
Yeah, Dr. Ankit, what type of plate you are using?
So I'm using the Indian-made Tomofix copy.
So these are not this variable angle plate. So what is your tips to prevent to put the screw, anterior screw, screw, and simultaneously avoiding your ACL tunnel?
Sir, so this plate does have a 5 to 10 degrees angle variation that is there. This plate is, even though it's an Indian copy, you can still angulate it slightly posteriorly. The locking mechanism will be effective still with the 5 degrees angulation. Second thing is the plate was put quite posteriorly. If you notice my post-op X-ray, the plate is put quite posteriorly to prevent the anterior most screw and the anterior tibial coalition. Because it is not variable angle, because I do not have the liberty of variable angle, that is the reason just putting the plate more posteriorly has assisted me in most of my cases.
So you are keeping something in your tibial tunnel just to avoid.
Yes, sir. I've got an X-ray. I've got a CM picture of that. I put a so the CM picture that I showed was of a chondrocyte harvester. I normally use the same size reamer. The reamer that I've used, maybe one size lower also, just put it inside. In fact, even the back end of it also, just to prevent, so that even if I hit it, I then change the angle slightly and then go more posteriorly for the anterior most screw.
And always you complete your tibial tunnel before going for HTO.
Yes, sir. Because I finished my scopy work and then go ahead for my high tibial osteotomy, because I have to get the C-arm in, and that is on the same side as the scopy trolley. So that's the reason I finished the scopy work, and it's a little difficult otherwise for me.
Okay, good. Nice presentation.
So can you, Dr. Ankit, can you play with the slope so that you can don't have to do the ACL then? Because in a HTO you can change the slope to control the instability also, so that you can get away with the. What is your opinion regarding that?
So with the open wedge osteotomy, sir, it is slightly more difficult to change the posterior slope as compared to a lateral close wedge, where you can change the slope to a greater degree. And so a lateral close wedge is a little bit more technically demanding in my hands, sir, so far. And that is the reason, playing with the slope, there are surgeons who do only posterior slope correction and will not do the ACL reconstruction, and it does work in their hands. In my hands, I have not achieved it yet. There are
Okay.
surgeons who propagate it.
Thank you. Very nice skills. Any question?
You said that you did your superficial MCL release first,
Yes.
and then you did your
Yes.
meniscus surgery. So you made an
Yes.
incision for your HTO first, did the superficial MCL release, and then you did your scopy.
So graft harvest is the same incision as your HTO plate. If you technically go to see if the oblique incision is a similar incision to your hamstring graft harvest. After harvesting the graft, you can easily go and access the MCL, and you can erase the MCL of the distal tibia. So by doing that, I have opened up the knee joint, and it's a tight knee. Most of these patients have a tight knee. By doing arthroscopy first, it is always a struggle to reach the posterior root. To reach the posterior root is slightly more difficult. So therefore, taking off the graft and then doing a release and then going and doing the diagnostic arthroscopy, it really aids in doing all your meniscus work. So that is what I do.
Thank you. Thank you.
Thank you, sir.
Okay, any other questions? Okay, so we have come to the end of this IAS corner. And initially, it was an excellent talk by Dr. Deepak sir, and very nicely explained about the double bundle ACLR, why he is still preferring the double bundle ACLR. And then by Vinay, very nice cases, 3 cases, excellent cases. And lastly, Ankit has nicely demonstrated his technique of HTO root repair and ACLR. So over to Dr. Sandeep for the concluding remark.
No, thank you very much, sir. You have very well covered all the concluding remarks. So Dr. Deepak Chaudhary has shown us that double bundle ACL reconstruction is still relevant. As he has mentioned, 60% of his practice still are with double bundle ACL. And Dr. Vinay gave very good insight about the post-arthroscopy knee pain and the management, a nice case presentation. And Dr. Ankit has shown how do we navigate or prevent the coalescence of the tunnels of ACL root repair in a varus knee. Excellent, all the speakers, and Dr. Soumyadeep and Dr. Ranjit Panigrahi were the good moderators. They have covered all the topics and all the questions in detail. Thank you very much. And I would like to thank Dr. Tirth and Dr. the viewers. Thank you very much. So, Naresh, please end the meeting.